Hello and welcome everyone. Canwell, you are now free to start.
Good evening, everyone. I'd like to welcome you all to this joint Facebook Live between the Royal Papworth Hospital and Cambridge University Hospitals. I'm really excited to be able to sit here and ask questions and introduce you all to the superstar surgeons and our superstar anaesthetist as well, so that they can tell you what it was like to be part of this programme, The Surgeons at the Edge of Life, and their experiences in it and what it is to be a surgeon in this day and age. Obviously, things have changed a little bit since the programme was made. We're now in an era of a pandemic and COVID, and we have to think about what that means in terms of how we provide care for our patients. I'm really pleased to be able to say that we're still managing to provide care to our patients in a way that is safe and secure. So that is both at Papworth and at CUH. So we want to keep you all safe when you visit us, and we're doing everything we can to enable that. So back to the main agenda. I'd like to just quickly introduce everyone that we've got. So we've got Charles Malata, who is one of our senior plastic surgeons. I should say Prof. Charles Malata, actually. He's one of our senior plastic surgeons at CUH, and he was involved in episode 2, which was the chest wall reconstruction for Kevin. Then we've got Emmanuel Huguet. Apologies if I get your name, if I say your name incorrectly. He's also a transplant surgeon and carried out the Whipple's procedure in episode 4. Ronan O'Leary was our hero from episode 1, and he is one of our senior anaesthetists and was involved with the pelvis and hip operation. Marius Berman is one of our transplant surgeons from Papworth, and he was involved in the double lung transplant in episode 3. Ravi De Silva is a cardiac surgeon who was involved in who carried out the aorta replacement in episode 4. I have to admit, my heart was in my mouth for most of that one. And then Aman Kuna, who's a thoracic surgeon who, along with Charles Malata, double act, carried out the chest wall reconstruction. So actually, I'd like to hear a little bit more from each of you about what you like and what you do. So shall we start with you, Emmanuel?
Yes, thank you very much. And good evening, everyone. And thank you very much for your interest in our work. So my name's Emmanuel Huguet. I'm one of the consultants at Addenbrooke's Hospital. My area of work comprises two subspecialties. One is called hepatobiliary, and that's surgery of the liver and pancreas, usually for cancers within those organs. And the Whipple's operation that was shown in the series is a prime example of that. And my other area of work is liver transplantation. Apart from the day-to-day tasks relating to those specialties, I have a role in coordinating liver surgery in this region, and I have a research interest in liver regeneration. I really enjoyed being part of this series and seeing how it was put together. It's been fascinating to see my colleagues' work, and I think all of the episodes really showcased the depth of care that exists in our hospitals, and also the amazing teamwork. So thank you very much for your interest in our work.
I'm looking forward to hearing more. So Ronan, would you like to go next?
Thank you. Yeah, good evening, everyone. I'm delighted to be invited. I didn't expect to be called a hero. So that's the first experience I've had in my life in my 8 or 9 years at Addenbrooke's, and thank you. I'm a consultant anaesthetist, and I'm also, in most of my life, I'm the lead consultant for the neuroscience and trauma critical care unit at Addenbrooke's Hospital, and that takes up all of my life at the moment. So by coincidence, the Harrington's case was the last case I did as an anaesthetist in Addenbrooke. I haven't been back to theatre since, but it's not because of that case, it's because of the COVID pandemic, and my life has been completely taken over by that. But so my main interest is neuro and trauma critical care.
Thank you. Charles? Oh, you're on mute. We finally got the statement in of one of us on mute.
Thank you very much, Kano. And thanks very much, everybody, for coming this evening to this Facebook session. I'm Charles Malata. I'm a consultant plastic surgeon at Addenbrooke's Hospital here in Cambridge, and I've been a consultant here since 1999. I'm also a research professor at the School of Medicine at Anglia Ruskin University. At Addenbrooke's Hospital, I specialize in breast reconstruction after mastectomies, likely for cancer or patients with a breast cancer gene for risk-reducing surgery. And my special area of expertise and experiences in microvascular surgery. I've also got a very active research, clinical research interest, and I supervise some PhD students, some of the medical students, registrars, and who are undertaking different clinical outcomes research projects. I was really very excited about this program because it kind of showcases what's important in teamwork. And in plastic surgery, we're always working with other surgeons, other specialties, and we pride ourselves on being team players and bringing, I guess, a different sort of expertise to the table. I know I think we're running a little bit behind. I think I'll end there for the time being.
No, we're fine. We're fine.
Okay.
Don't worry. Okay, Marius.
Good evening, everyone. My name is Marius Berman. I'm a consultant cardiothoracic surgeon at Royal Palbot Hospital. I'm also a cardiothoracic transplant, and I'm passionate in organ retrieval. I've been doing that since being a medical student for, well, I have more hair and more black hair, to be honest. I've also work in this domain in NHSBT, promoting organ retrieval and more of implementation of novel technologies in order to increase organ utilization. And thank you very much for the invitation to take part in this program tonight.
Thank you. Aman?
Good evening, everybody. Thank you for your interest, and thank you for all the comments from my brilliant colleagues who have spoken before me. It's been very exciting to be involved with this series. I've been thrilled with the teamwork and the ability of the film crew and how they've put it all together. I'm a general thoracic surgeon covering the full range of thoracic surgery. I trained in London and North America before coming to Cambridge. I was appointed in 2006. I'm very lucky to work with colleagues such as Charles Malata and many other brilliant people. I have an interest in tissue regeneration and have a research program in that area. And also I'm involved in large data projects looking at several thousand people who have undergone thoracic surgery operations and looking at outcomes. I love being involved in education. I was the national student lead for our specialty, and I find the opportunities in education with new technology and all the innovation going on absolutely fascinating. So I'll stop there for now. Thank you.
Thank you. And then finally, Ravi.
Thank you very much, and thanks again to everyone who has logged on. I'm Ravi De Silva. I'm the lead aortic surgeon at Papworth. I trained at Papworth many years ago, and then was a consultant in London and Oxford, and returned back to Papworth 6 years ago. So my major interest at work clinically is aortic surgery, and beyond that, I'm quite a keen educationalist and training program director for East of England cardiothoracics. Outside of work, I like to think I'm just a regular guy. I like keeping fit. I've got 2 beautiful kids and a wonderful partner. So yeah, that's me.
Lovely. Thank you very much for the introductions. I'm going to start actually just with some general questions. I might direct them a little bit towards people. And these are all questions that have been sent in to us, although I may put a spin on them. So the first question was around, there are a lot of people in theatre, and why are there so many? And how do you all know what you're going to be doing and not get in each other's way? And I'm going to send this one towards Ronan, because I think your theatre probably had the record for the maximum number of people in it. So how do you manage that?
Yeah, I think it was a lot of people. I think it's fair to say that isn't normal for an orthopaedic list to have that many people showing an interest in theatre, particularly halfway through. I think it's probably useful to talk about the sort of broad staff groups that you have in theatre, and that you have the surgical team, which would typically be 2 or 3 medically qualified surgeons. They'd be supported by nurses, scrub nurses and runners and so on, who'd be assisting with the operation. The anaesthetic team would typically be 1 or 2 anaesthetists and supported by a colleague, an operating department practitioner. And then there may be 1 or 2 other members of staff doing various roles. In the Harrington case, you may recall that we had to press the emergency buzzer, and what that does is it sends an alert out throughout the whole theatre complex to say that there's a life-threatening emergency in theatre, and so anyone who's free really would come to help. So what happens is a lot of people arrive, and as the situation's assessed, they're given tasks, and they do those tasks until they're needed, and then they're sent away again. So initially there's a very big spike in people that come, and it dissipates very quickly as the situation resolves itself. So that was a very unusual situation. Typically it would be something around 8 to 10 people would be in theatre normally.
Okay, so Charles, Aman, you are both based at different hospitals, but then you were operating together. So how does that feel with the different teams, and how do you coordinate all that?
Maybe Aman can start.
Thank you, Charles. Everything that happens with Charles Malata when I'm working with him is very smooth. It's as we mentioned in the episode, we've been working together for several years. I really have to say that it all happens almost seamlessly. The Addenbrooke's team are all very professional. They know what they're doing. Our team welcomes them. They know what they're doing, and we play our respective parts. Charles, what do you think? What do you think? Yes,
I mean, I've been very impressed by the welcoming nature of the team at Papworth. But in addition to that, we do have a team brief at the beginning where we outline exactly what the surgical plan is. It may not always go on to plan, of course. That's the nature of plans. And I think there's mutual respect and understanding of the various skill sets involved, and it's worked very, as Aman Kuna says, it's worked very seamlessly over the years. And now I'm pleased to note that Papworth Hospital is now on the grounds of the Cambridge campus. So it's made things much easier, because all we have to do is walk along the link corridor to get to Papworth, rather than driving sort of 15 miles west.
So I noticed that when I was watching your episode, there were some very familiar faces from my theatre teams, actually, that were there. So Charles, do you drag your team along with you?
Yes, it's very important to take the microsurgical team from the plastic surgery theatre across the way. It's not only because of the complex equipment, the microscope and the microvascular instruments we use, but they're also very familiar with the various steps. A lot of this surgery is very intricate, and very time is a factor, and literally the ability of nurses who are absolutely excellent, the ability to pass us the right instruments at the right time, and more importantly, their anticipation of what's going to happen next and so on is absolutely vital. So I brought a team of two other plastic surgeons, my registrars, Metin Nizamolu and Manuela Roman, in addition to our nurses from the plastic surgery, maxillofacial surgery, eye surgery team from Addenbrooke's Hospital.
That's fantastic. So next question would be, how do you ensure that the patient stays comfortable during surgery? What signs do you look for? I'm going to put that one to Marius, actually, because that was a big op that you did.
Yes. Some of the feedback I got after the program is that it didn't came across that actually it was an 8-9 hours operation. We were very far from Amas and Charles' record, but not that far off. So there are a lot of safety measures before we put the patient to sleep, and then throughout the procedure, the interesting spin, and Emmanuel will, I'm sure will agree, in transplantation, we try to minimize the time that the patient is in theater, but a little bit of the unknown factor is the fact that in vast majority of cases, the donor is not in the same hospital. Yes. So we rely heavily on coordinations who are doing a brilliant job. One of them, Daniel, came across in the program, in order to minimize the amount, the ischemic time that the organs are outside the body. And obviously it translates to the amount of time that a patient spends in theater. We do ensure that we have breaks, which is good both for the patient and for the surgeons.
Okay, so just in general, you're all in different specialties, but how did you decide which specialty you were going to go into? What drew you to it? I'm going to start at the bottom of my screen and go for Ravi at this point.
Well, I liked everything that I did, to be honest. I really enjoyed all my house jobs. I enjoyed basic surgical rotation training as it was then. And but one of the things I did in that was thoracic surgery. And when I did that, I thought, wow, this is really good. And I rang up someone at Papworth and asked them, well, I want to be a cardiothoracic surgeon. What do I need to do? And they said, well, you need to go and get some cardiac experience. So I went and did cardiac surgery at the Brompton. And then fell in love with it from there. So I think it's not that I haven't liked any other type of surgery. I really have. But for me, I think cardiac surgery represents personally the greatest challenge for me. So that's why I fell for it.
And what about you, Emmanuel?
It's an interesting question, isn't it? What draws us to where we end up? And I think it's quite difficult to identify what we seek and what attracts us to different areas. For myself, as for my colleagues, I think it's a mixture of designed and chance. Certainly in my specialty, I've met like minds and people who share a passion. I think also, and I think this is true of all my colleagues, we've all chosen areas, different subject matter, but areas that will present us with infinite challenges. I don't think any of us will ever be master of the territory. The horizon will always be far away. There'll always be new challenges, and I think that's to many of us, that's very attractive. I'm certainly very conscious that my specialty will always be bigger than me and keep me humble. So in general terms, I think that's what's attracted me. It's the prospect of forever being challenged.
So, Ronan, I'm going to ask you as well, because obviously I'm biased as a surgeon and we've got a group of surgeons here. Why didn't you not become a surgeon?
Well, I'll let you into a secret that no one at Addenbrooke's knows. I started as a surgeon and went into intensive care, and I managed to keep that secret for the last 8
You
years.
escaped.
So for me, it was I really like the physiology and the pathology in surgical diseases and critically ill surgical patients, but I enjoyed the intensive care medicine and the process of having critically ill patients, resuscitation and stabilization more than I enjoyed the practical aspects of operating. So I drifted towards intensive care medicine, and a convenient way to do intensive care medicine is to start as an anaesthetist. So that's how I found myself in this specialty.
Thank you. So we've had a couple of questions come through on the Facebook. I'm actually going to combine two of them because they're in the same sort of ballpark. So I've got one from the Papworth group from Nicola. How do you support your own health and well-being to enable you to perform consistently at a consistently high level throughout any procedure? And then linked to that, we've got one from the CUH book from Yasser, and he asks, how do you manage the stress level as well as the pressure during the operation? Is there a special training, or is this by experience? So who'd like to volunteer for talking about your general well-being and then how that translates to how you are in the operating theatre? Otherwise, I'm going to pick. Okay, Charles, we're going for you again. Mute.
Maybe let me start by answering your previous question. I was drawn to plastic surgery really by the, I mean, I met fantastic teachers and mentors at St. James's University Hospital in Leeds while training as a general surgeon. I mean, Professor Simon Kay and Andy Batchelor, and then later on Neil McLean in Newcastle were absolutely phenomenal people who were doing such fantastic work. And I thought, I want to be like them. And they're doing all this challenging surgery. I think that was, for me, the stimulus or the impetus to become a plastic surgeon. And then I went to train in Glasgow at the Canisben Hospital. And that's where my interest in reconstructive surgery really came to the fore, the microvascular reconstructive surgery.
So these are big operations you do. So how do you manage that? Physically, mentally, how do you manage it?
Yes. Well, I mean, we do take some comfort breaks. I mean, we're not there all the all the time. And during the 18-hour operation, we do take a couple of breaks to have something, something to eat. Particularly something to drink, because you get dehydrated very quickly because you're under the operating lights. They're quite warm, then wearing heavy gowns, and of course the adrenaline is flowing, so that doesn't help in terms of well, feeling under pressure and so on. But there are also natural pauses in the operations we do. So when we've finished one part of the surgery and we have to turn the patient to the other side, for instance, that provides a few minutes while the patient is being prepped and re-draped and so on, to be able to take a break. But it is very intensive. You need a lot of concentration, and this has basically come, because of years and years of training.
Yes. Okay. I'm going to go on to another question. So Hannah's asking from the Papworth group. I'm a second-year student nurse and have always had a keen interest in cardiothoracic care and surgeries. What advice would you have for her to learn more and pursue a career in cardiothoracic? So I think that's for Aman and Ravi.
Hi. Well, if I start first, I think just get involved, just come along to Royal Papworth Hospital. If you're, are you already at, I think you're already at Royal Papworth. Well, make it known that you're interested in that area. Try to find out what it is that you like doing, whether you like working in theatres or the perioperative side of the care, and there are specialist courses that you can do offered by Papworth and other places. Some of our nurses, after a period of time, become advanced nurse practitioners who specialize in dealing with very unwell patients or perioperative management. Some people head towards transplant. I think there are a lot of opportunities, and the nursing team and doctors and others would be very happy to talk to you about that. Ravi, would you like to add anything?
I think you've given a very exhaustive and good answer, to be honest. The key thing is, whichever area Hannah decides to go into, just remember that you could be in it for years and years. So make sure you sample every aspect of cardiothoracic surgery and nursing to really decide where you see yourself for the long haul. And then, as Aman said, there's multiple ways in which you can progress in your career thereafter.
You'll never get bored.
I'm going to ask some specific questions now that were given to us beforehand from people that sent them in beforehand. And I'm going to start with Emmanuel. So the Whipple procedure looks very complex. How do you ensure that everyone in the team knows what they're doing? How do you ensure that effective teamwork?
Yes, the team question, I'm actually very pleased that's been raised as a topic of discussion, because the series, perhaps understandably, inevitably, has focused attention on one aspect of the patient's journey, the time in theatre in particular. But of course, for all of us, none of this can happen without massive input from so many people. And we're talking about pathologists who tell us what kind of tumor we're dealing with if it happens to be an oncological specialty. For all of us, the radiologists provide us with amazing imaging that allows us to plan surgery. Surgeons and anaesthetists work together very closely. We have our theatre teams, anaesthetic teams, the post-op recovery people, the staff on the ward, the specialist nurses who glue everything together, and all of the communication that happens to support that, secretarial stuff. So the list is endless, really. How do we coordinate? Well, I guess there are a number of elements. In any particular task, we always try to ensure that there's an appropriate mix of senior and junior members of a team. So there's a constant atmosphere of education, of transmission of knowledge, of experience. That is also dependent, the coordination of the team is also dependent on good communications, and some of that comes about through inbuilt infrastructural things. So these days we very much work as teams, in multidisciplinary teams. Ward rounds provide a means of communication. Then there are cultural and personal aspects. So there's no doubt that I think both at Papworth and Addenbrooke's there's a culture of respect, of approachability, of friendliness, and I think that facilitates communications and therefore coordination.
It's a lot around communication, isn't it?
It's fundamentally about communication.
Yeah, definitely.
Partly infrastructural and partly personal and cultural.
And we saw a lot of that in the series, that the talking between you as surgeons leading and working with your teams very closely. So Marius, I'm going to come to you next. So the question is, I loved watching the double lung transplant because it was done differently from when I had my double lung transplant 10 years ago. Not me, this is the person who sent the question. How has the operation changed in time? And just before we say, I just have to say, when I was watching that and the lung unfurled like a flower, oh my God, the joy of that moment was amazing. I honestly, I just looked at it and thought, oh, it's just opened. It's amazing. So yes, how have things changed?
Over the years, so the journey, as Emmanuel touched on, starts way before the transplant itself. Obviously, the surgeons, when we do a transplant, we need to bear in mind not just the clock, which is in the theaters where we are operating, but also in the donor. And we need to be mindful where the rest of the organs will go, mainly the liver, which is as sensible organ as the heart and the lung. When I say sensible, it's meaning the ischemic time. To answer the specific questions, in the past 10 years, there is more and more new technologies involved in order to increase organ utilization. The organ donation itself is increasing in UK. There is a huge amount of work done by NHSBT, anesthesists, specialist nurses, and so on to increase and promote organ donation, and including the new law which came into in May this year. However, the population in UK is one of the donor population is one of the oldest compared to the rest of Europe and North America. So the lungs in particular has one of the lowest utilization in the world where we're in UK. So we have to use, compared to 10 years ago, more and more new technologies in order to assess, reperfuse, resuscitate the organs in order to make them transplantable. The incisions, there was a lot going on. The crew liked the friendly competition between Pedro and myself about the size of incision. The incisions, there's nothing new there. They are more or less classic incisions. There are 3 or 4 of them that have been in practice for the last 4 or 5 years. And it happens so that as soon as Pedro left Papworth a few months ago, and it happened so that the following 5 transplants were through a very, very large incision. And the patients did very well as well. So so just to summarize, it's not necessary the incisions that change, but the quality of the organs, and we need to work much harder in order to find good lungs to transplant nowadays.
So a very quick question that's just come in, which sort of comes onto the back of what you're saying is, so what is the recovery period for a double lung transplant? And what would you expect the average improvement in life expectancy to be? So
the usual recovery is between 2 and 3 weeks in hospital. It's very much dependent on the type of incision that we do. And it depends on the pathology, but the life expectancy is very good. And there are various pathologies for which there is an indication for lung transplantation. But survival is very good.
Okay, thank you. I'm going to sort of ask another, I'll come back to some specific questions in a minute, but I'm going to ask another general question. These two go together. So one was from Maureen at CUH, is for the cardiothoracic team. Is the team looking into doing robotic surgery, and do you have a surgery program? And actually, the other thing is, how do you keep up to date with the latest technologies in surgery? And that's from Rai at CUH as well. So that, I think that will be for Aman and Ravi.
Robotic surgery is probably, so at Papworth we don't have a full-scale robot at the moment. At Addenbrooke's Hospital you have more than one robot which are used in different specialties. It's something that we'd certainly be keen to get into. We have for nearly a decade been using a robot-assisted telescope device, which gives us a very stable image and allows a single surgeon to operate, and the robot will manipulate the telescope into a position that gives a very stable view. That's called the freehand telescope system, and it's actually very, very effective and very low cost. I think that we would really like to get involved with this, and it is part of the direction of travel for thoracic surgery. A number of units have embarked on it. I'm sure Ravi will want to say something about the cardiac side. With regard to innovation, it's terribly important, and in fact, it's one of the reasons that I got drawn into the thoracic side of our specialty. It was at the beginning of the minimally invasive revolution in thoracic surgery, and there was a lot of technology coming in, which I found fascinating. It's very important to keep a very open mind, not to stay tied into your technique just because you do it very well, and constantly be aware that there are changes, there are better ways of doing things, and to be critical in when exposed to new technology, because it's not always better, but to keep it patient focused. Ravi and Marius, you're both cardiac surgeons. Any thoughts?
Well, certainly doing robotic cardiac surgery is something which I think we need to aspire to. Papworth has a lot of other commitments in other areas which perhaps have taken up time and money, but certainly it's something which I'd be very keen to explore. And as for staying abreast of current or the new developments, well, it's imperative that we as clinicians do that, because we have to continue improving what we do. And certainly, I think that if we end our career doing an operation the same way as when we started it, we've failed. So we really have to try our best to innovate, but do it with caution and obviously with the patient's outcome and their interests at the very center of everything that we do.
Thank you. I'm going to move into a different area, and this one's for Ronan. And it was commented on that you worked really well with Andrew as part of a team. So what makes a good relationship between an anaesthetist and a surgeon? And actually, it sort of also leads into a question from Chris CUH, who's asked how important the nurses whilst you're performing surgery or anaesthetics. So yes, what does make that good relationship?
I think the second part of that question is probably the more useful part of it. I think Andrew and I both feel very lucky to be doing that list together. I think our relationship is, we're fortunate that we got appointed, I think, within a year of each other. We're both Irish in background. We both have kids of similar age. We both go to the rugby together, all that sort of stuff. So we've been able to build a good friendly relationship, and we have a similar approach to understanding the medicine and the risks and the decision making around patients. But I think the more valuable part of that list is that we've worked with the same group of nurses and other colleagues who in what is Theatre 16 at Addenbrooke's for all that time. So every Wednesday, the same group of people who get along, are pleased to see each other, enjoy working together, and see value in innovating and trying to push forward with complex work in rare and difficult disease. And I think the wider team, as Emmanuel and others have commented, is as valuable. So I know Andrew and I are both very widely supported by colleagues in our own departments, recognizing that it's complex work that comes with risk and so on, and provide sort of resilience and support throughout colleagues and throughout the hospital.
Yeah. Okay, thank you. Okay, so I'm just checking through my questions that what I've got from. We've talked quite a bit about communication, and the episode with Kevin, there was a lot of discussion about how you do the surgery and making him feel safe and that it was the right thing to do. So, Aman, how did you assure him that this was the right thing for him and that he was in safe hands?
I think in Kevin's case and in all cases, it's really important to establish a relationship, to be honest, to be realistic, to understand what it is that's driving the patient, to try to make sure that they understand and you understand them, and to see the problem that they have in the context of their life. It's not just a whole, it's a very difficult experience going on over very many years. I think that in this sort of operation, I think the potential complications are very important to be realistic about. And as you'll be aware, initially Kevin decided not to go for the operation. And it was 2 years later when he made the decision, because he had, as he said, he'd reached the end of his tether. I want all of my patients to feel that they can approach me with any problem. I am as open with them as I can be. So in explaining, it's not about ticking a sheet of questions. It's about making sure there's a thorough understanding. I usually don't want people to sign a consent form the first time I meet them. I want them to go away to reflect on it, raise any more questions, and then document their decision, even though if it's already made. So that's my view.
So, Charles, I mean, you were involved with Kevin as well. Did you, and he's obviously with Aman for quite a long time. How was it when you became involved with that case, and what was the hardest thing about reconstructing his chest wall?
Well, I think if I just echo what Aman said, and that's a realistic presentation of the various options available to the patient, and also the pros and cons of each of those. Because in plastic surgery, we do have a number of options, and we discuss those frankly with the patient, and the possibility that this operation may or may not work, and what kind of percentages, or this might pose a risk to their life in this case, etc. And he came back to clinic a few times. In addition to that, we assisted in the decision making by various scans and so on, not just of his chest, but of his blood vessels, to at least looking at their patency and so on. It's not a decision that you went into lightly. I think some of the challenges that we had with Kevin were the fact that he had also lost a lot of weight, and therefore a lot of the tissues which we would normally use to transfer were just not existent, because he was so slim. And then additionally, he had a chronic wound with chronic inflammation and so on for a long time, making for a lot of scarring. So really, the most difficult parts of Kevin's operation was really in the decision making before surgery as to what option we're going to use, but also the scarring and so on we encountered, some of which we'd really not been were not anticipated. But I guess after several years of an open wound and so on, but it also affected the other side. The microvascular surgery itself is straightforward, but the technical problems of the access, or the limited access for us to do these surgeries, that's the I think that was really the hardest part. And I guess if someone was asking about robotic surgery, I think those are the areas in which I would see robotic surgery in plastic surgery, is where we have a difficulty of access, for instance, in the upper airway for big flap reconstructions after intraoral cancer and so on, or for reconstructing after breast surgery, going between the ribs, preserving the ribs and so on. And of course, in the cases like Kevin's, where access is limited and the 360-degree degrees of freedom in terms of motion, that will come in very handy. But also another area of robotic surgery is harvesting flaps. I think that's something that I think plastic surgeons will get to use in the future in robotic surgery.
Yeah, thank you. So, Ravi, I'm going to combine a couple of different questions for you. And one of it was around when you were sewing up that carotid, it was quite friable. It looked like it wanted to shred. What would you have done if that had happened? And actually, it makes me think, how do you keep one of the questions, how do you keep your hands steady enough to actually do this work? Is it no coffee in the morning?
2 cups of coffee for me. The hand steadiness, I'm sure all of us have different tricks we utilize, but for me, it's about posture, making sure the tables are the right hand, that you're not stretching too much. So that's how hand steadiness comes into it, I suppose. When things like the carotid arteries start disintegrating in front of you, well, you've got to work with what you got. So to begin with, what you see is a bit of a problem, and then you try and rectify it, and then it becomes a bit more of a problem, and you try and rectify that. And we as surgeons, we're always thinking about the next possible step and what to do if it all really doesn't work out. And I suppose the end result of that would be that I'd have to not do an anastomosis to the carotid, and perhaps finish the operation as quick as I can, and pick up the phone to one of my vascular colleagues in Addenbrooke's and ask them, some of those that specialize in carotid surgery, for advice, and maybe even to come and do some sort of bypass operation. So that's I suppose that's the end result of everything going totally wrong.
Yeah, it's very hard when it goes. You know that those things can happen, and you do everything you can to stop it, but sometimes it doesn't quite go the way you want it to.
But I think it's really good to phone a friend, and we've all got good colleagues at work, and so to be able to have someone there to be another sounding board for your problems is incredibly important. So yeah, it's
good to know that you have that. And I think as a surgeon, I go home at the end of the day and think about what I've done, and it can play on your mind, particularly if you have a tricky case, a difficult case. What do you all do to close that theatre door behind you when you go home and reset? I'm going to throw this open. Who? I think Aman's smiling too much, so he needs to answer that. I think this is where the 2 dogs come in. So,
well, the dogs have run away because more children have arrived. We have 6 children. My wife says they're all mine, and hers. We have a boisterous home life. She's a consultant as well, and she's actually just come back from doing an emergency. You might have seen her bend over and take something from behind me and then sort of pull a funny face out of shot of the movie. So a lot of the work we do is demanding, it's challenging, but work is definitely a relaxation in my life.
Okay, Marius?
It's important to have. It's a difficult question because it's linked also to your previous question, how you balance your life and work, and all of us, even now, because we are passionate about what we're doing, we are willingly to take part and share our experience and our journeys and our beliefs. I don't think you're really, I mean, definitely my situation, you completely disconnect. You always have in the back of your mind, particularly when you have a patient which is particularly sick in intensive care, and you try and think if you could have done something different, call a colleague, as Ravi said. But at the same time, make sure that you balance and you give the attention. Arman mentioned the children and the rest of the family. So you make sure you do balance that, which is important for the surgeon to keep going for the rest of their career.
Okay, lovely. Does anyone else have any things that they do which, you know, to create that work-life balance, that's slightly unusual hobbies or?
No, I think it's very difficult, as other surgeons have said, it's very difficult to switch off. And I think it's very difficult, you know, not to let your family kind of suffer in terms of that they don't have enough attention from you and so on. I'm afraid, I'm sure most surgeons, I think this is a problem.
Yeah.
And I too, like most people, find it very difficult to wind down, because when you get home, because you're always thinking about, you know, what could have been done better, you know, how is that patient faring, you know, is the flap working, and things like that. But I really enjoy watching comedies, you know, on the television, and on the weekends watching my beloved Newcastle United playing football. So those things I think help.
Can I add something, please? Because I'm saying this for the people in training out there, or people who are having a difficult time. I certainly, and I suspect that many of my colleagues have been through times where it's almost been overwhelming, or has been overwhelming. And I know that my family actually endured me being away a lot. And I am sure that at certain times I've damaged my personal health because of my obsession and passion for what I'm doing. And right now I'm in a much better place. And I think the lessons I've learned, which are about resilience, about actually making some time to go away, about trying to keep fit, watching one's weight, staying away from having time away from the computer and social media. I think those are all really important things. And for me, and maybe others, those things help me do better. So it's definitely something that needs active management and awareness of.
Do you think physical fitness is really important?
Massively important. Marius and Ravi and probably Charles will laugh at me at how big I got, and I thought I was just strong.
How tall are you?
No, I am tall, but I mean, you know, carrying the wrong sort of weight, and it wasn't even denial. It was just a complete lack of awareness, and I think that at times people doing our sort of job can lose insight into their own health, their own physical and mental needs. And I think those things are actually really important. And I'm very happy to talk about them. I know that when I was in training, these things were not spoken about. They were pushed to one side. And I think it's really important that we recognize those things and deal with them actively.
So, I mean, this takes back to an earlier question that I didn't actually ask at the time, but someone said, what are your shift patterns like? What is it that you work? And I mean, I'm very lucky. I'm in a very elective specialty. I plan when I'm doing things, my surgeries are about 3 to 4 hours on the whole. But particularly with the transplant surgeons, how do you manage that transplant could come in at any time?
I would make a start. What is a shift? In transplant, you're right. I mean, essentially, you answer that, particularly in cardiothoracic, Papworth, which at present is the largest UK cardiothoracic transplant, does about 100 transplants per year. Probably this year less because of the COVID. So, but it's so unpredicted. So, for example, we haven't done a transplant for a couple of weeks, and then suddenly we can have 3, 4, 5 during one weekend. And it's important to have this mental flexibility when things are more relaxed, more down, to going back to the family questions and to do things for yourself and for the family. And sometimes it can get very busy. Ravi mentioned about working with friends. So in transplantation, sometimes we have very difficult cases. They are on the waiting list. In cardiothoracic, they can wait sometimes for years. So on the night, the offer comes and it's suitable for them. And you need a friend. And that's what we do. So even if we are not on call, if a friend calls and asks, like on the night when I've called Pedro, I was on call, but the previous night I've done a complex case. And I thought for the sake of the patient, it would be better to have 2 surgeons rather than just one tired surgeon. And Pedro came and we've done. So particularly for transplantation, organ retrieval, I would say in order to be successful and committed, you need to have this flexibility.
Yeah. Okay. Just thinking about what it takes to go into sort of medical specialties such as critical care or surgery. Ronan, were you squeamish at all when you were younger, or have you just always managed to cope with this? Or if you were squeamish, would this stop you being able to do one of these careers?
I don't know. It's interesting, but I don't think I was squeamish or am squeamish. I think there are squeamish people who are surgeons, and there are squeamish people in theatre who are able to disconnect the reality of an operation from the squeamishness of a horror film or something like that. So I don't know that squeamishness in itself. I think probably within all of us, wherever we came from, whatever job we do, there's a fascination with pathology and physiology and the living pathology and the sort of physiology of the patients we treat. So I think you probably have to have some sort of visceral interest in diseases and pathology to enjoy the work we do.
Yeah. Has anyone else got any thoughts on that and what it's like to be a surgeon and how you end up in that position? Okay.
Shall I give you a little answer to that?
Yes.
I actually started off doing internal medicine. So I did MRCP first, which is for the people on Facebook, membership of the Royal College of Physicians. And after doing that, I went into the lab for 2.5 years and did molecular genetics. And it was through that journey that it crystallized to me that I actually really, really wanted to do surgery. And the root of that was in medical school. I was fascinated by it, but I had an injury and I thought I couldn't do it. So I suppose that the message in that is that if you've got a calling, go in that direction. Try and do what you enjoy. Yeah.
Yes, there are so many different types of surgery as well that you will find something that works for you, if that, like you said, if you have that calling. And I don't think being squeamish necessarily stops it. You just find something that works better for you. So we're sort of coming to an end, but I'm going to drag it out just a couple of more minutes. Just thinking about the filming, and it's a different way. You're being watched, and you've got the cameras. How were they able to film so closely? What was it like having the team with you in the theatre? I'll go with Emmanuel on this, because you look too relaxed.
Yes, the film crew, the presence of the film crew is definitely very strange from the outset. I'm not an actor, either by profession or personality, so it was odd. Having said that, the film crew were a great bunch of people, really very friendly, very professional, and so they made it all okay. I was fascinated by the process. I was fascinated by the hours and hours of footage that they take in the seeking of the perfect shot, the perfect view. I was astonished by the number of repetitions that were required. And then in terms of the theatre, I thought the way they blended a number of different views, fixed cameras on the walls of the theatre, cameras on the theatre lights, mobile cameras within the theatre, headlight cameras. I thought it in the end provided them with a wealth of material which allowed myself, other viewers to appreciate what my colleagues were doing in a way that I wouldn't otherwise have been able to appreciate. So I thought it was a fascinating process, and ultimately, actually not nearly as obtrusive or intrusive as I thought it might be. So in the end, I was not disturbed by their presence at all, actually.
Okay, so a question for Marius and Ravi. How do you ask the patient?
So can you clarify, how do I ask a
How
patient?
do you ask them to be part of this? What was the process? How do you approach it?
Oh, in David case, it was very, David the patient, it was very easy. I didn't ask. I didn't wanted them to feel any commitment that there is a condition or there will be. So and I have to applaud the filming crew and the filming team. They've done a fantastic job, and the whole consent process, and we have to mention not all patients were comfortable with that. So I know that they've approached several patients and their families, and but I was completely separate from the process. So I think that was the right way to do, so nobody felt pressurized to accept being filmed in a procedure which carries risk of life. So again, congratulations for the filming team. They've done a fantastic job.
Patients are very brave, aren't they, to allow this insight into their care. And I mean, Ravi, how did you find that with your patient?
Well, I think like Marius, a lot of that goes down to the patient's generosity and their trust in us, but equally the approach that the filming crew had to them. I mean, as Emmanuel and Marius have said, that they're a really nice bunch of people and they're really easy to work with. So that would have obviously had an impact on the patients and perhaps made them feel that they were willing to give us that insight into their illness, treatment and recovery, which is incredibly generous, and not just for the patient, but also for their relatives, to be honest, that they would allow potentially quite difficult moments in their lives to be broadcast and seen around the country and perhaps even around the world. So I think that it's amazing that they allowed us to do that. The personalities of the patients were, I mean, our patients are an amazing bunch. So they just seem to be really willing and open to these ideas.
Thank you. I think we're going to draw it to a close here now. And there are some questions that are still outstanding, and we will try and get some answers to those and get back to the people who gave them to us. But I'd like to thank you all for this absolutely fascinating insight into what it's like to be a surgeon, what it was like to be part of the programme, and also to reiterate our thanks to the patients that were involved for allowing us to take part in their journey and in such an intimate way, and showing us the relationship between themselves and you all. So thank you very much. It's been wonderful talking to you all.